And if it's black, let me know.
Let you know. Then I call the operator.
That's right.
How many does it have? What's the goal? What's the big ta-da that happens in the first stage?
Dilation.
Cervical dilatation, effacement, and descent of the fetus. Even though we say that's actually correct. And what happens in the second stage? Yes, have the baby. What's the third stage? Have the placenta. And the fourth stage? First 4 hours after birth. Yes, first 4 hours after delivery. Okay. So we probably don't need to talk about that a whole lot more. Let's just get to our assessments. Are these on your notes?
We stopped pretty much at nursing and labor.
Thank you for the video.
Well, Cornelia said it. Feel free to snap a picture if you want. Again, these are just words. It doesn't tell you everything you need to know, because what you need to know besides these words are what do the words mean and what are you going to do. So when it says the first stage assessment for mom is effacement, well, you need to have an understanding about what is effacement, how is effacement measured. You need to understand what is dilatation, how is that measured, how is that related to the different phases of the first stage. Station, which we're going to get to that now. Fetal station has reference to do with the descent of the fetus. And as the labor, progresses, dilatation and effacement, the fetus will descend. As you can see there, at the level where there's a 0, that's the level of the ischial spines, which are palpable during a vag exam. Now, on the lateral side of the vagina, and there are these projections here. So when you do a vaginal exam, you can feel these bumps. These are ischial spines. So when I'm doing that, then I kind of draw an imaginary line from here to here. And then I'm saying to myself, where is the presenting part, which is probably a head? Where is it? Is it at this line, or do I have to reach up and find it? Or am I reaching below the line to find it? That takes obvious talent, skill, practice, right? So when we say they're at the 0 station, that's what it means. It's at the level of the ischial spine. Or, this is a positive thing. So when the fetus says, hey, I'm at 0, from here it's all positive. I'm on my way out. At some point, they need to get to 0, then it's measured after that. The measurement below 0 is 1 centimeter, kind of like the fundus, right? 1 centimeter below 0 is +1, +2, +3, +4 is generally considered on the floor. Kind of like that 4th tequila on the floor, 1 tequila, 2 tequila.
3 tequila, 4.
3 tequila, 4, right? So it's kind of like that. 4, some people might say 5 on the floor, but it helps you remember more if you do it in tequila, I think. But anyway, so that's kind of what station is. So not only during the process of labor do we need to know the dilatation or effacement, but the station is the fetus coming down. This is what my daughter-in-law's fetus did not do. She effaced, she dilated, and the little devil did not descend. And she did a good job. He was not term yet because of her condition. They induced her, and he just wasn't ready yet. Have a question?
Terminology, you would just say fetal station +1? Like,
Yes.
That's how you would say?
That's how they're recorded, +1, +2. Absolutely. And so when the physician comes in, and in her case she was like 6 centimeters dilated and ballotable. You remember what allotment is, right? Her fetus was allotable at 6 centimeters dilation. That ain't right. So at that point, really you have 2 considerations, 2 things they could have done. Cesarean or artificial rupture of the membranes. Then he may have engaged himself, but he's ballotable. It's not like he has to come down just a little ways. He's got to come down. And so that risk of what is happening is present when they rupture the membranes and they're ballotable like that. Where we just talked about the risk with ruptured membranes. Ruptured membranes cause a risk of prolapse of the cord or compression of the cord. And the physician, in this case, the healthcare provider said, technically I can do that, but I'm telling you I'm not going to because it's too risky. Because he wasn't just not coming down, he was higher than -3. You touched him, he still floated up. You know, so, anyway, she wouldn't do it. Because sometimes when you break membranes, it causes the labor to pick up and makes it go good. But you don't do that when there's a lot of them. You're still gonna have to be somewhere in the ballpark there. Okay, so now we can go back. So that's what you have to know about sedation, is that 0 is at the level of 0. From then it all becomes positive. Fetal position, we know the fetal position, we know the fetal lie is either transverse or longitudinal. We know that the fetal position will either be cephalic, which means what's down presenting in the pelvis?
The head.
The head. And if they're breech, what's presenting? Probably their bottom or their sacrum, right? Probably their sacrum. And a fetal position of transverse lie, or would be, what would be presenting? Their shoulder would be presenting. Comfort, of course, is very important to our patients, but just because our patients are uncomfortable does not mean they want to be medicated at all. So, you know, a good assessment, if they don't have a birth plan for you, constantly you're asking and evaluating your patient. There is nothing wrong in labor and birthing when your patient says they have a score of 100 out of 0 to 10, 10 being the worst, and you gave them and did nothing, or gave them nothing. But did you do something? That's what JCO and everybody else is going to be looking at. What did you do? Because your patient stated, I don't want any medications of any kind, no anesthesia, no analgesia, nothing. But did you do anything? Well, yes, you offered them mount care, you turned them, you massaged them back. If they wanted it, you got them a fan, whatever it is to make them comfortable. Now, in Med-Surg, it's a little bit different, and if your patient says, well, it's a 5 or a 6, but I really don't want to take anything because I want to be alert, I would record 5 or 6, and I would definitely amend or addend that note. My patient's 5 or 6, and you don't see any corresponding medications because they said this, right? Or somebody can come back and say, you tortured them, right? Because if your patient says they have, you know, pain over 5, we're supposed to be doing or giving. So you better at least be doing and writing it down if you're not giving. Doesn't matter who your patient is. Because they can come back and, you know, people tell lies sometimes too. I know it's very moving. What is their contraction pattern? Of course. We're looking for, how do we evaluate the contraction pattern? What are the parameters we're looking at? Frequency, duration, and intensity. That's right. And then vital signs for the month. And also INO, very important. You're not going to have an order that says INO on your patient, but you better be doing INO on your patient. Okay? There probably will not be an order, and we're talking standard orders that are probably 4 pages long. But nowhere in there will it say hourly INO or anything, but it's your responsibility. Because when that bladder fills, the scent of the fetus will be stopped, and that will probably stop later. So it's important, as well as you don't want to be overloaded. So, and support person, and how are they doing? You know, if the support person is more concerned with what's on television and reading a book or talking or playing on the computer or whatever, you can try to engage them at a certain point, but at a certain point you might just give up and just count them kind of out of it. But at any point that support person decides they want to tag back in, then they can tag back in, right? Especially if it's a partner, okay? You can't say, hey, look, I've been doing this, I'm here, you don't even know what you're doing, you better watch TV. No, you're like, okay, come on. You know, it's a little annoying because now you've got to catch them up to speed because, you know, they said they were going to go to the cafeteria and get a bite to eat. Well, apparently they were at Florida Hospital, went over to Hooters and had a picture before they came back so you could smell it. And so now they want to be all, you know, involved. But still you have to involve them. That might have even happened with students in the past, I'm just saying. Who said, oh, I didn't know we couldn't go across the street very much. And your beer. Okay. First stage of the baby, we're assessing the fetal heart rate, and we establish that we know the normal range, which is 110 to 160. It's tricky, Selma. Yes, 110 to 160 for fetus, 120 to 160 for baby. I don't know why they couldn't just like everybody just come to a consensus, go up or down 5 or something. No. Variability, we're familiar with what that is. The variability of the heart rate is not always the same thing, a straight line. Deceleration, we're going to look at in more detail in a moment. We know acceleration because that's what we looked at in terms of what prenatal test were we looking at acceleration? NST, non-stress. Reactivity is a word that you might have already heard in clinical, and you may hear again. Reactive or reactivity, my baby's reactive, my strip's reactive. That's how you'll hear your nurses talk, and what they mean is, I have acceleration, with or without fetal movement, they don't care. I have accelerations of variability. My strip is reactive, my baby is reactive, even though they're really talking about a fetus. They'll say, my baby's reactive, I'm good. Or my strip is, they'll say. But that's what that word means, okay? It means you have acceleration and variability. Okay. So just a little labor, women's health humor. I guess we do need to know that Leopold's maneuvers will help us to assess fetal position, presentation actually, and position. And there are 4 movements to it. You really don't do this as registered nurses. I don't think I'm going to show you the video. I don't think it's that good. So I'm using it actually. You other people have seen my video. Sasha, did you like that? No, maybe you weren't. So anyway, Leopold's maneuvers is, and there's a picture in your book that they look pretty much like these, is to assess the fetal position and presentation without ultrasound and without a vaginal exam, because it's usually done in the prenatal period before dilatation and effacement. So they want to know, is this fetus head down or butt down? Okay, that can be important, right? They were doing a version, but who was at Florida Hospital with me in labor and delivery the other day? TT, was that you? Were you in labor and delivery last week?
Yeah.
Yeah, who was with you?
Ashley.
That's why when I asked that question, nobody answers it. Okay, so they were going to do an external version, right? Try to turn a baby from breast. But did they do it, or did they do it after you left?
They didn't do it. The baby decided.
Oh, it turned around, or oh, it was too far down. They couldn't do it, so they probably had to do a cesarean then, right?
No, they didn't do a cesarean. She had it in VD, vaginal delivery.
Oh, well, maybe it turned itself. They can turn itself. But anyway, so this is what you're doing. You're feeling here first, and you want to feel if it's rounded or if it's a butt. Because if it's rounded and hard, it's your head. If it's rounded and soft, it's a butt. And then we feel on the sides. And what you feel on the sides is where there's back, it's nice and smooth. And you can feel all the way down, you can press. This takes a lot of pressure. This is why nursing students don't do this. I mean, there has to be a real reason to do this, okay? Because you can imagine it can cause uterine stimulation and delivery for preterm labor. So you're feeling for a small back. If you feel a back over here, what are you feeling over here? Arms, legs, elbows, knees. What do they feel like? Nice and smooth? No, they feel like bumps. You got a bump. It's either a foot or a knee or an elbow or a hand or something. But the backside is nice and smooth. So then you kind of know, where the fetus is in that reference. You've determined up here whether it's a hard, rounded prominence or if it's soft and squishy. And then you just double check yourself again. Now here you can go like this. I mean, you guys are not going to do that. But again, to check and see if the head is in position. And just double checking again with this one, which side is smooth and which side has bumps. Because the bumps are, what? Hands and feet, right? Because when this fetus is in utero, and I'm feeling, regardless of what position it's in, but when I'm feeling its back, this is what I feel, nice and smooth. But when I feel the uterus on this side, I feel the bump, right? There's a little bumpy, so it's not nice and smooth. Okay. Okay, let's see. there's some? You call a friend?
It is.
She's ready. Good. Don't let me throw you off like that.
Second guess.
Be committed, believe. Okay, so, some more details on the, see, I wrote baby, that's bad. I'm gonna have to tell you now, and it's on the recording, that's not baby, it's fetus. And I wrote that on there too. So this is the first stage for the fetus and not the baby, okay? Don't let that confuse you, because it could. So we're monitoring the fetal heart tone. We can do it internally or externally. Externally is what you've seen. Did anybody, who has not seen a fetal monitor on somebody yet?
Oh, yeah.
Did you see one?
No, I didn't.
Everybody else has seen one?
I've seen one on my wife, but not at clinical.
Oh, that's okay, you've seen one. So that's the external, the Doppler is external, that's picking up the fetal heart rate. And we already know about the baseline, and we know about acceleration. The other way we can measure is by using a fetal scalp electrode. Now, similar to the intrauterine pressure catheter, the fetal scalp electrode has to have some pre-existing conditions with it, which would be what? Like the intrauterine pressure catheter. What condition did the mother have to be in? Ruptured membranes and dilated so we can get in. Same thing here. This is, and I'll pass it around, but don't sue me like the coffee's hot or something, because this is sharp on the end. And if you poke yourself, bleed, and get a community-acquired MRSA, I will not be responsible. It's out there. Huh? That's right, it's on the recording. Don't delete it. It'll be like that Watergate thing. It'll be silence. Okay, so this is just a guide again. This comes out and gets connected to a wire from the monitor. And this will measure the fetal heart rate constantly, regardless of the mom moving or the fetus moving. So if you have a strip where you can't really get a good strip and you're missing things on the fetal heart rate, or the fetus is just moving around a lot, you might want to choose to do this. And so this little piggy tail sharp thing screws into the presenting part, which 97% of the time will be the head. Literally, it just screws in there. What do you think the fetus is going to do when they screw that in its head? We'll have to do its heart rate. It'll go up. Anytime something is done to the mother or the fetus during labor, it's important to document it on the computer or paper. In the old days, we literally wrote it on the paper, but now on the computer, because if they come and they say, but look, the heart rate went way up here. Like, what caused that? What did you do? What did you not do? You can say, well, it's because the healthcare provider screwed in a fetal scalp electrode, and that's a normal response. Okay? Or during a vaginal exam, even that's documentable in relationship to the strip. So as things are changing in the strip, you can see what procedures and things were done, because that's your defense of how you were aware and what you were doing. This shows where we might listen for fetal heart tones. These are very specific based on position. You do not have to know this. What I do expect you to know, though, is this, which I don't have a picture of. But if the fetus is head down, where in relationship to the umbilicus would you expect to hear? Now, all I've told you is they're head down. I haven't given you any other details. Where in relationship to the umbilicus would you expect to hear a fetal heart tone? Below it. Agree?
Yes.
What if this presentation was breech in relationship? Where would you expect to hear it? Above. And what if this was a transverse lie or shoulder presentation? At the level. I think that's all you need to know. I really don't think somebody's going to ask you in relationship to this position where you're going to listen. Boy, I hope that's right. Okay. So this is how you put in a fetal scalp electrode. You don't just poke the thing in there. It's always guided by fingers until you get to the point, and then it's screwed in. Okay? And then it'll come out and be unscrewed at some point. And in fact, you'll see little boo-boos on the baby's head sometimes. They'll tell you to put some antibiotic ointment on it or something like that, because there'll be a little boo-boo from where the screw in. That is not a technical term. So, questions on first stage assessment of the fetus on this page? not baby confused. So here is a contraction pattern, and what we're seeing here are contractions on the bottom. And do we see anything good in the fetal heart rate?
Yes.
What do you see? Yeah, I see variability. And the rate looks good. Okay, that's good. Here's minimal variability. So you see how that fetal heart rate line looks different than that one? It's almost like a straight line. And again, presence of variability means that the fetus is well oxygenated and has an intact central nervous system. So when, at about 32 weeks, preemies won't necessarily have that. But you can see how that's important. We expect them to have an intact central nervous system. We expect them to be getting adequate amounts of oxygen. And if they don't, they may lose their variability, and that's concerning. We don't worry about that. Now, here's an abbreviation, or not abbreviation, we call that an acronym for memorizing the different types and their causes of deceleration. Maybe you'll want to know this. We have 3 kinds of deceleration, but to make a nice word, somebody added acceleration in there. Okay, so we can make the word veal. Okay? I guess there's no word V-E-L. Doesn't really make a word, so they want to make veal. So variable, early, acceleration, and late. So what causes a variable? And I'll show you some pictures in a moment. Cord compression. So what causes cord compression? Could be a couple of things, but one we've already talked about was that the fetus is on top of the cord, because when the water broke, the membrane is ruptured. It fell under the head or got contracted, and I'll show you some more in a moment. But you do need to memorize. Variables are caused by cord compression. Okay? Early decelerations are caused by head compression. That's normal. Remember, there's nothing to do for that. Head compression is completely normal. Acceleration means they're oxygenated. And again, that's just to make a nice acronym. Late means poor placental perfusion. A list of about 10 to 20 things on the maternal side, equally as many on the fetal side. We're not going to memorize those. Okay? Just know it's poor placental perfusion. At some point, we're going to want to know what is causing the poor placental perfusion. But if it's very poor, we don't have time to worry about that. We just got to fix it. We might figure out what caused it later, and sometimes we never do. But there are a bunch of things that can be investigated. But most importantly, it's just getting rid of it for right now. Okay? So memorize that page. Anybody have a question about memorizing that page? Now, will that be enough? No, you're going to have to know what they look like and what are you going to do with them. Because that's what we do. This page right here.
Oh.
You need to memorize that, okay? Because I'm going to ask you a question that has something to do with one of those decelerations and what its cause is, and or what are you going to do about it? And you're going to need to know how to answer that question. And if you miss that, it's because you just didn't memorize it. You didn't think fast, and I'm going to tell you what you need to know. Okay, early decelerations. We talked about those already, right? It's always okay to get early for class, early for dinner. That means it's completely normal. And it's caused by head compression. And that's completely normal. So if we review, it's early because of where the deceleration, meaning where did the fetal heart rate start to go down. That's right. Okay, so it started to go down right here. So remember, it's all in relationship to the contraction. So here's the contraction, the middle of it. Everything on this side, if it begins to go down over there, it's a what?
Late.
And if it begins to go down over here, it's early. And variables can come anytime. So this, now if I give you a picture on your exam, it probably will not have the dotted line. You're going to need to draw the dotted line yourself. Okay? So if I give you a picture of a contraction and a fetal heart strip or a little bit of one, you're going to need to know that what you need to do is find where it starts to go down, draw your dotted line in reference to the contraction, and decide if it's on the early side or the late side. So in this case, it's early. And what are we going to do for an early deceleration? Document and reassure your patient there's nothing wrong. But it doesn't mean you don't document it. Okay, you still document it, it's normal. It's sort of like a normal, it is normal for a woman at 36 weeks of gestation to have hypotension laying in a supine position, and you would document that, right? And in this case, we would turn her, but it's normal. You didn't do anything wrong, she's not having an event or whatever. That's abnormal. So, abnormal, all right. So do you understand kind of what I'm saying, what we talked about before? Here's a little less, but kind of the same picture. So here are the contractions, here's the deceleration. So if this were your Scantron, you could use that. It's going to be on your test if it is, you're not going to be able to use the page on the test. I would say, hold my paper and say, okay, where's the baseline? Okay, I see the baseline right out there, okay? And you can see, where is it not? Like, where do you not see it? Because it's going to be covered up on a piece of paper. So you're going to see that it starts to go down right there. So you draw your line just right inside this line. Is that early or late on that contraction? So that's early. Okay. Another picture.